Welcome to Health Frontiers, where we explore the uncharted territories of well-being. I am Dr. Robert Lahita, also known as Dr. Bob. With over 50 years in rheumatology and immunology and 17 years as the chair of medicine at 3 major medical centers, my mission is to simplify complex medical issues for you. Join me as we uncover the latest breakthroughs in health, answer your pressing questions, and discuss nutrition and holistic living. This podcast is all about empowering you with the knowledge and tools to manage your health effectively. Let's embark on this transformative journey together. This is Health Frontiers with Dr. Bob, and I'm Dr. Bob. And today I have a lot of medical news which has developed over the last few weeks. The first story, which is fairly big, is about measles. Now, measles is a very big contagious threat. Vaccination has emerged as one of the most crucial advancements in public health, offering protection against various infectious diseases, not just measles. But measles is certainly the one that everyone as a young child gets immunized against. And that's very important, as you'll see. This contagious viral illness poses significant risks, especially to young children and individuals with compromised immune systems. It can lead to severe complications, such as pneumonia, something called encephalitis, which is an infection that involves the brain and the tissues of the brain, and even death. And therefore, we need to understand the importance of vaccination in combating measles. And that's essential for safeguarding public health and ensuring community well-being. And I know full well, as do you, our audience, that there's measles again in various parts of our country. And it is a very serious public health problem. Measles is caused by a virus which belongs to a family with a big name. It's called paramyxovirus. It primarily spreads through respiratory droplets with an infected person who coughs or sneezes. The virus can remain alive on surfaces and in the air for several hours, making it highly contagious. If you're in a room with somebody that has measles, say a child, almost everybody in that room is at risk of having this infection. The symptoms typically appear about 10 to 12 days after exposure and include a high fever, a cough, a runny nose, red eyes, and a distinctive measles rash that usually starts on the face and spreads down into the rest of the body. While measles might seem like a typical childhood illness, its complications can be severe and even life-threatening, as I mentioned. First of all, pneumonia. People think measles is just a skin problem, but it's not. It's very, very serious. And depending on your immune system, you could react in any one of 100 ways to this very, very lethal virus. First, pneumonia. This infection can cause serious lung infections. That is one of the leading causes of death in young children. The second is this brain infection that I mentioned called encephalitis. It's a complication involving inflammation of the brain, which can cause permanent brain damage, long-term brain damage. And the other complications are it can lead to ear infections, diarrhea, and in some cases, a condition known as subacute sclerosing panencephalitis. Now, that's a big term, but believe it or not, I saw 2 cases of that when I was training as a young doctor. So it is something that is a fatal brain disorder that occurs years and years after the measles infection itself. So vaccination, coming back to that, and it's very controversial now because our new Health and Human Services Secretary is so-called middle of the road as far as vaccinating young people goes, although he says he is for vaccinations when vaccinations are needed. It's the most effective measure in preventing measles and measles outbreaks. It's typically administered to children as part of the MMR, so-called measles, mumps, and rubella vaccine. That's what that stands for. It stimulates the immune system to produce antibodies against the measles virus, providing immunity without causing the disease. The benefit of vaccinating against measles are several. The prevention of the disease, it reduces the risk of contacting measles, and community immunity. High vaccination rates lead to herd immunity, protecting those who cannot be vaccinated, such as infants, pregnant women, and individuals with certain medical conditions. And third is the reduction in healthcare costs. Preventing a measles through vaccination helps reduce the economic burden on our healthcare system by avoiding hospitalizations and treatments associated with the disease. And I like to remind our audience that healthcare in America is a $4.7 trillion with a T, $trillion cost annually. So this is a really important thing that I am sure is going to be front and center with regard to the Senate and Congress going forward. The global impact of measles vaccination has been profound. There was a decline in measles, widespread immunization in the days that the World Health Organization was promoting this vaccine. Global measles deaths have decreased by 73% from 2000 to 2018. And in fact, in 1982, it was everybody believed that measles was no longer a problem in America. And now it's back. And that's because of the shrinkage of the world. But the deaths decreased by 73% from 2000 to 2018. And now we know that the deaths are beginning to increase again, largely among children. So what are the eradication efforts? Some regions have eliminated measles through rigorous vaccination programs. For example, the Pan American Health Organization declared the Americas measles-free in 2016. But maintaining this measles-free status requires continued vigilance and continued vaccination. So despite the proven efficacy of measles vaccines, there are challenges and there are misconceptions and misinformation out there, particularly for certain groups that are against the use of vaccines in children. It is not a good thing. And that's my first message for today's News in Medicine. So let's talk about another topic that's very popular and a little bit easier to understand. And that is, why do women tend to outlive men? A very popular question. So I'm exploring longevity and the differences in gender. Throughout history, one notable trend that has persisted across various cultures and society is the longer lifespan of women compared to men. This phenomenon has intrigued all of us, scientists, researchers, and doctors of medicine, for decades, leading to many studies aimed at unraveling the reasons behind this disparity. Several factors contribute to this longevity gap, and it ranges from biological differences to lifestyle choices and social determinants. One of the primary reasons women tend to outlive men is rooted in biology. The genetic makeup and hormonal differences between our sexes play a significant role in determining life expectancy. Women get or have two X chromosomes, while men have one X and one Y. That's what makes us men. This chromosomal difference gives women a genetic advantage. The X chromosome carries a number of genes on it related to immunity and cellular repair. If one X chromosome has a defective gene, the other X chromosome can often compensate for it, providing a form of genetic backup. Men, us, on the other hand, do not have this redundancy. This genetic advantage may help women better withstand age-related diseases and conditions. The silent X give the aging female brain a boost. And this is from the University of California Research Laboratories. Females carry two X's, as I mentioned, and a cell confines one of those X's within the cell to something called a Barr body. This thing sits in the corner of the nucleus of the cell. We really didn't think that the Barr body could do much, But the University of California at San Francisco team discovered that as mice reach the equivalent of 65 years of age, and in a mouse, that's about 20 months, the second quiet X chromosome in the female mouse began to activate and express genes to bolster the mouse's brain connections. This actually increased the mouse's cognition. So the mice were able to think a lot clearer, and I'm sure you're out there saying, well, how do we know that? But as the research biologists in murine studies go, they can look at a mouse's intelligence by the way it moves around its nest, by the way it finds its food, etc. So the conclusion is that women often have younger-looking brains, that's true, and fewer cognitive deficits. Age awakened, like the sleeping X chromosome, is very, very important to a female's longevity. Now, there are hormones that play a significant role in this. Estrogen is a hormone predominantly found in women and has protective effects on their cardiovascular system, the heart, and the vessels of the body. It helps maintain the elasticity of the blood vessels and reduces the buildup of harmful cholesterol, thereby lowering the female's risk of heart disease. And such diseases are a leading cause of death. And this hormonal protection can contribute to a woman's longer lifespan. In addition to the biological differences that I just mentioned, lifestyle choices and behaviors significantly influence life expectancy. Women generally engage in healthier behaviors and are more proactive in seeking medical care. Don't we know that? As we'll hear perhaps from our guest who will be on in a few minutes, that men don't like to go to doctors. And when they do go to doctors, when the doctor gives them advice, they don't always follow instructions. That is not the case for most women. Studies have shown that women are more likely to adopt health-promoting behaviors, such as maintaining a balanced diet, exercising regularly, and avoiding harmful habits like smoking and excessive alcohol consumption. These behaviors contribute to better overall health and lower the risk of chronic diseases, ultimately leading to a woman's longer life. So they're more likely to seek medical attention, get checkups every year, and preventive care such as breast screenings, reproductive organ screenings, and, of course, vaccinations. Early detection and treatment of potential health issues can prevent the progression of disease and improve their survival. Men, on the other hand, are often less likely to visit healthcare providers regularly anyhow, which can result in delayed diagnosis and treatment. Social and psychological factors also play a significant role in the longevity gap between men and women. Social support networks, stress management, and coping mechanisms can influence this life expectancy. Women typically have stronger social support networks compared to men. For example, these networks provide emotional support, practical assistance, and a sense of belonging, all of which contribute to better mental and physical health. Social interactions, women have more of that, can reduce stress and promote a sense of well-being. And that's all important as far as longevity goes. Women often employ different coping mechanisms and stress management strategies compared to men. They're more likely to seek social support and express their emotions, which can help mitigate the negative effects of stress. Chronic stress is linked to various health issues, including heart disease, weakened immune systems, and all sorts of metabolic problems going forward. The types of work and environment exposures experienced by men and women are different and can also impact their life expectancy. Historically, men have been more likely to work in physically demanding and hazardous occupations, such as construction, mining, and manufacturing. These jobs carry a higher risk of injury and exposure to harmful substances, which can negatively affect health and reduce life expectancy. In contrast, women are more often employed in less hazardous occupations, although that is changing now, but that can contribute to their longer lifespan. However, if they get involved in more hazardous occupations such as construction, being police officers or firemen, this could affect longevity. Men are more likely to engage in risky behaviors and activities that expose them to environmental hazards, such as extreme sports or dangerous hobbies. These can increase the risk of accidents and certainly injuries. Additionally, men are more likely to be exposed to environmental pollutants and toxins, which have long-term health consequences. So you can see from what I've just said that the longevity gap between men and women is a multifaceted issue influenced by a combination of biological effects, lifestyle effects, social involvement, and environmental factors. While biological differences such as chromosomal and hormonal advantages play a significant role, lifestyle choices and behaviors, as well as social and occupational factors, contribute to the disparity between the lifespans of a man versus a woman. So a few more news items, and these are rather brief, but very, very important. The first one is a study which was completed by PLOS, and it was dated March 5th, 2025. And this is from Canada, from the University of Calgary, suggesting that the symptoms of menopause can predict neurodegenerative disease in older women. While we're talking about longevity, the woman lives longer than a man, her chances of having neurocognitive deficits increase with age. But we just found out from the study of 896 women post-menopausally that if you have symptoms that are significant, your chances of getting a neurodevelopmental or dementia as you get older is enhanced and increased. This is from the CAN Protect study. That's the CAN, which is Canada Protect study out of the University of Calgary. Women who reported experiencing more menopausal symptoms were more likely to show signs of cognitive decline and neuropsychiatric issues later in life. Each additional menopausal symptom was associated with a higher score on cognitive function tests, showing more consistent symptoms of cognitive dysfunction. Researchers linked each additional symptom to a higher score on a behavioral impairment test, showing more behavioral symptoms. And the study also found that hormone therapy, that's HRT, hormone replacement therapy, was associated with fewer mild behavioral impairment syndromes. So the hormone therapy, which you can really consult with your gynecologist and obstetrician about, they will guide you into taking the appropriate hormonal replacement therapy. I know there's a lot of fear out there among women about the use of replacement hormones, but used with professional assistance, and that can be an injection, it can be a pill, or it can be an intrauterine like suppository, will provide you with the hormonal replacement that you may need to, number one, obviate the symptoms of menopause, and number two, prevent neurodegenerative disease as you get older. The last thing I want to talk about, which is kind of interesting, and I like to produce one of these periodically for this show, is the next generation of antibiotics. As you may know, we have infections that occur in people that kill them. And the reason some people succumb to infections, particularly pneumonia or sepsis or renal tract infections, is that the bacteria causing the infection are often resistant now to antibiotics. And that's becoming more and more common. And why is that happening? Well, I'll tell you, we did a show a few months back where the infectious disease expert said that's because antibiotics are being used by doctors inappropriately. And it's very common for a patient who's feeling terrible, coughing perhaps, maybe bringing up some phlegm, but not running a fever, to go to their doctor and say, hey, put me on an antibiotic. So the doctor says, okay, I'll put you on something. And he does, or she does. And that organism, which may go away on its own, is now being exposed to an antibiotic. And by mutation and by constant use of antibiotics where they are unnecessary, the bacteria become resistant. So we're always looking for new antibiotics. And this last story, in fact, is quite interesting because we know as biologists, as well as doctors, that most antibiotics come from the soil. And if you're astute out there and you know about the origin of antibiotics, they come from molds many times. And actually, some of the newest antibiotics have even come from sewage. Believe it or not, sewage. And that is, in fact, the development of new antibiotics, which we are running out of, actually. So from the last place you look, that was the philosophy, you always find something new in the last place you look, in quotes. And this was an Australian study that was published in PLOS, is another really excellent scientific journal, not medical journal, but scientific journal. It was Australian oyster blood. Australian oyster blood. Now, why oysters? Well, antimicrobial proteins and peptides, which we call AMPPs, are among the most promising agents for fighting microbial resistance. And in fact, oyster blood, it's got another name. I believe it's something like lymphoprene or whatever. Marine invertebrates like mollusks, which involve oysters, clams, do not have an acquired immune system. They don't have an immune system like mammals do, like we do, to fight off pathogens, those foreign invaders, those bacteria. So they don't produce antibodies against pathogens. So Dr. Kirsten Benkendorf at the National Museum, the National Marine Science Center in Coffs Harbour, Australia, began to look for antimicrobial substances in mollusks, and she deserves a lot of credit for this finding. Researchers publishing in this journal, PLOS 1, found a major antimicrobial substance with activity against organisms like pneumococcus, streptococcal pneumonia, a very big cause of death in the elderly, for example, or a cause of death in those people who get measles, like children who get measles with inflamed lungs. So they found that this oyster blood, if we can call it that, so exciting, was very, very effective in destroying not only strep pneumonia, but 6 other respiratory pathogens, saving the lives of experimental animals in which these infections occurred. So that's a rundown of news, starting with measles, talking about why women live longer than men, talking about a new study on post-menopausal symptoms, and finally on oyster blood as a new kind of antibiotic for those resistant infections. And now we'll have it gives me great pleasure to bring in our guest for an interview. Well, hi, everybody. We're back. And I'm very happy today to be joined by Dr. Alex Kimmel. Dr. Kimmel is an instructor at Columbia University College of Physicians and Surgeons, and he is a board-certified rheumatologist. And he's the first rheumatologist we've had on this program. But I'm going to ask him about a very, very important disease called gout. The public knows very little about gout. And I'm always questioned, and I'm sure you are, Alex, always questioned about what is it that I have gout. Maybe you could give us a little bit of history about gout and tell us exactly what it is.
Absolutely. Thank you for having me. It's an honor and a pleasure to be here.
It's a pleasure.
As a rheumatologist, well, before even rheumatology, in internal medicine, we would see patients with all kinds of different arthritides. And I didn't realize that gout is the most common inflammatory arthritis that's out there. And usually the patient presents with excruciating pain in one of his articulations, and one of his, usually the feet, that say it came out of nowhere. I can't bear weight on it. Something's terrible. And the usual presentations, they think they did something wrong. They think they wore the wrong shoe, that they broke their toe, that they hurt their toe, even though there was no trauma. And the pain is so bad, the reflex that they have is run to get Advil, Aleve, whatever they can, and they medicate with that. But they don't realize that the underlying issue is that there's something metabolically wrong.
Often it's confused with a fracture.
Correct. Yes.
It's that painful.
And it depends on the severity of it and how bad the pain is, but majority just over medicate with Advil relief till the pain goes away. But if it doesn't, they seek attention. They go to an urgent care, and the urgent care goes, wait a second, there's no fracture here. There's nothing wrong. But they get blood work and they start seeing that the patient might have metabolic syndrome when they realize the patient, and it's very common in metabolic syndrome because the patient's overweight. It's usually their diet that is triggering the uric acid overproduction. And they're told, on blood work, sometimes we see some abnormalities. We think that you should really consider diet and exercise and so forth.
Is it more common in obese people with diabetes, for example?
Very much so.
Uh-huh.
It truly is. Majority of the patients are, well, there's different subsets of who gets gout, but most commonly it is patients with metabolic syndrome who are overweight, pre-diabetic or fully diabetic, anybody with kidney issues because they can't get rid of the uric acid and it keeps building up. And it was always throughout time known as the gluttonous disease through the old ages, through the kings, because they ate so much meat and fatty foods and rich foods that these high purines would cause, the purines are the proteins that trigger uric acid buildup, and they would get these terrible gout attacks.
Yeah, now this goes back to Columbus and Queen Isabella. I remember the story about the drug that was brought back to the civilized world by Christopher Columbus, which it was called the disease of kings. Am I right?
Correct. Yes.
And that was because they ate the most food, the best food,
Correct.
and the richest food.
Correct.
Yes. And they would be attacked.
Yeah.
And there are many, many medieval prints of kings or cartoons.
Correct. Yeah.
Of things biting their feet.
It's so interesting, because it's they can't walk, and the patients, when the gout patient comes walking and they're limping, they don't have their shoes on. It's one foot's in a shoe, one foot's in either a bandage or a sneaker or something else, because they couldn't walk for the last 2-3 days because of severe pain. And when you ask them to take off the bandage or the shoe, you see right at the bottom of the first toe, it's usually red, swollen, and angry. And the one typical saying that they say is, I couldn't even put a sheet on my foot because it was that painful.
Yes.
And these are a lot of trigger phrases that make me think that this is probably what it is.
Yes.
And then I ask them, well, tell me more about your diet. I try to dissect of what brought this on. When they say, I didn't have any trauma, I didn't have anything else, I've never had this before, but I drank a 12-pack of beer the night before, and I don't drink any water, and I love my seafood, and they have all these other typical triggers for this gout.
Yes.
So
gout is, you mentioned uric acid. Is uric acid in everybody?
We all have uric acid. The only issue is that us as humans are missing one enzyme called uricase.
Yes.
And that's the enzyme that breaks down uric acid.
Yes.
So we need to limit the amount of, some people produce little bits of it, some people produce excess of it. But the metabolic syndrome, the unhealthy diet, the being overweight, all this triggers more of a uric acid burden.
Right. To be sure, there are people out there, although this is very, very rare, that have metabolic abnormalities aside from, say, just the plain old gout pathway, that have, extremely complicated genetic predisposition to high uric acid. Correct. So what are some of the conditions besides gout that you see a high uric acid in?
One is the genetic condition with Lesch-9 syndrome, where they can't break down the uric acid and it builds up. Yes. And it's the genetic abnormalities that they can't do it.
Yes.
So that's one of them.
Yes. And what about conditions like cancer chemotherapy and stuff like that?
That's a different perspective. When they have leukemias, lymphomas that have a high tumor burden, and they start giving them the chemotherapeutics, they kill off so many cells so quickly and lyse the cells, they create a tremendous tidal wave of uric acid. And the body can't excrete it that quickly because of what they're doing. They're actually treating the cancer, but creating this uric acid tremendous pool that can create horrible gout. So the only way they can really treat it is by tremendous IV hydration and using a medication called resburicase or pegloticase now that could actually break it down, because that the opening, the lysing of all these tumor cells creates the excess uric acid.
Now, we'll come back to pegloticase in a second. That's a big one. That's a new advance, by the way, not part of my news that I gave earlier. But why do men predominate with gout?
There's a belief that, and it's been found, that estrogens are protective for women. You hardly ever see gout in menstruating females from anywhere from 25 up to 55, but post-menopausally, they're fair game. I start seeing gout in post-menopausal women in their different joints, and the belief is from the estrogen being protective in the ability to excrete the uric acid.
Yes. And we also look for crystals in the helix of the ear. For example, as doctors, all doctors do this. If they're feeling your ears, people say, oh, you're feeling my ears. Why are you doing that? Well, they're looking for collections of crystals in the ear itself.
So if the gout gets that uncontrolled and you don't release the pools or lower it, it becomes tophaceous. So there's patients who actually get bumps on their extensors of their hands, their elbows, and if it super saturates that much, it goes to the coolest place of the body. That's why it's usually the furthest away from the heart. So they get it on their hands, they can get tophi on their knees, and tophi, as you said, on the helixes of their ears. And they look like little pimples. And I learned this a long time ago from this famous old school rheumatologist, Dr. Ralph Schumacher, bless his rest in peace. Phenomenal.
Rest in peace.
He said, always check their ears. And we're sitting there as fellows and saying, why would we check their ears? And exactly what you said, it super saturates there. He's like, you pop it, it looks like toothpaste coming out. And he's like, you get it, you put it on a slide and look under a microscope and there's your answer. You'll see the crystals there.
Yes.
And he was right.
Yes. And the doctor has to look. Well, most doctors don't have polarized light. That's a form of microscopy where the light fibers show you the crystals which turn different colors, because there are other crystals which we're going to mention from other conditions that can mimic gout. But anyhow, for gout, it's a very typical finding in polarized light microscopes.
Correct. And from all my years of training, it can look like gout, it can smell like gout, it might be gout, but the definitive way of knowing for sure, you have to look for crystals.
Right.
So patients can come in with terrible joint pains in their knees, their shoulders, where it may be, and it might go away in a few days. No one ever gets fluid out and they go, oh, you might have had just sprained knee. You might have had something wrong with your ankle. The only way of knowing for sure is putting a needle in, hopefully getting some fluid out and then you can say definitively, this is what you have, because you see under the polarizer, you see the crystal, the sharp crystals.
Right.
And that's when I would feel more comfortable starting to treat them.
Right. And you as a smart patient that's listening or seeing us would be worthwhile in saying to your doctor, did you check me for gout? And they may want to put a needle in the joint and get a little bit of fluid out. That's all you need to put it on a slide and look for the crystals.
Correct.
Yeah. So now let's go and talk about, and I agree with you, after the menopause, when estrogen is low, and we talked about that during the news section of today, when estrogen is low, women tend to get gout. Not all women, but if a woman drinks a lot of beer, for example, eats a lot of seafood, tell us a little bit of the difference between purines and pyrimidines. What exactly are they?
Purines, as they break down, these are the proteins of building blocks, and purines are more known as they break down, as you build up or break down too quickly, can form through the xanthine oxidase pathway. They can actually cause more uric acid accumulation.
Yes. That's a big item. So most of the gout patients that we see are sent either to a dietitian or just off the cuff are given advice. What kind of advice do you tell them? What kind of dietary things do you tell them to avoid?
To limit high purine foods, because purines are more known for that. So the foods that they're told to try to limit are excessive red meat. Okay. They have excess of sweet meats, sardines, seafood, but not so much fish. Some fishes, yes, but anything that crawls on the ocean floor and has a shell has been known to be more triggering of purines. Oysters as well.
Clams.
Correct. Shrimp, lobster, all the different ones to that. But my patients ask me, can I have salmon? And I think salmon has shown that that's actually okay. Some of
Really?
the fishes, yes. But they also said catfish is not. So there's a whole list that I'm sure you can put up on your website.
Right.
That would show which
they
ones.
can Google. You can Google things to avoid if you're afraid you have gout.
Yes.
Yeah.
There's a few. The other issues that are found triggering wise that is in the last 10 years, I think, or 20 years is high fructose corn syrup. Anything with high fructose corn syrup, Coca-Cola, these iced teas have had a direct correlation to uric acid spikes.
Really?
Correct, yeah.
And why would that be?
The way it's processed, the way the fructose is processed and how it breaks down into purines.
Huh.
It's truly interesting.
That's amazing.
And we tell them to limit their amount of Coca-Cola, of their soft drinks, into the other truly sweet drinks.
Wow, that's pretty interesting.
Yeah.
That's pretty interesting. Well, you mentioned tophi, and tophi are collections of crystals, and I've had patients over the years that have had such huge tophi, big collections of gout crystals, that they couldn't put their shoes on, for example. They couldn't use their hands. And some of them actually have had surgery to remove giant tophi. Tell us about those patients. What the heck is going on?
I feel bad for those patients. You still get a few of those coming through. Even in this modern day and age that we have so many treatments out there, I get a few patients these are the patients that are extremely resistant. They don't want to go see a doctor, no matter what. They don't see their doctor. They don't see anybody. They live the lifestyle they want to live, and they have these accumulations of these tophi all over their body, their hands, and they learn to live with them. And they still have flare-ups of gout. They get through it, and the tophi, because they're not taking anything to lower the uric acid pool. So all you're doing is you have a bucket of uric acid, you're adding more on, it spills over, and you're making more and more tophi all over your body. At that point, they go see whoever they can see in terms of their primary doctor. They see a rheumatologist.
Yeah.
Well, usually gout is started to be treated by the general doctor, and they're thrown a few medications.
Yes.
This population, gout patients, are probably the most extremely non-compliant of all the populations. They don't want.
It mostly occurs in men, and we spoke about men being non-compliant. They generally don't go to the doctor until they're unable to walk, and they're unable to sleep. And
pain's a good motivator for them.
Severe pain's a good motivator.
Yeah. So they have these tophi. They go to their doctor. They don't want to be on the medication. The tophi get bigger. So finally it becomes so cumbersome for them to be able to, they can't wear a shoe. They can't use their hand. So they said the easiest way of getting rid of it is go to a surgeon. And the surgeons actually say, look, we can cut off the tophi. We have to be very careful, but they can. And when they analyze it, it's all uric acid.
Yeah.
But I don't see so much of that anymore, because now we have really good treatments, as we mentioned before, which we'll talk about in a few minutes, but there's medications that can literally melt the tophi away, not so quickly, but it absolutely disintegrates the tophi and brings them back into normal functioning.
Right. Well, 40 years ago when I was training, I remember at the Rockefeller University having patients come in with giant tophi, and we really didn't know what to do. Because as Dr. Kimmel's going to mention, the various drugs that we use to prevent uric acid from being elevated, and the ones for inflammation do not necessarily remove the tophi. So how do you start treating a patient with gout?
So I get Joe X. He comes in.
Yeah.
Nice construction guy. He goes out after work with his friends to have a few beers and a few drinks. Yeah. And he has his first gout attack at 23 years old. So he gets a few attacks every year. He does okay with it. The Advils, Aleve, all of these. All those do is just lower the inflammation, but they don't do anything for the uric acid burden.
Right. That's important. They lower inflammation, but they don't do anything to remove the uric acid.
Correct. And he continues his lifestyle until he reaches the point where he has severe attacks where he can't get out of bed because his wrist is so swollen from a gout attack that he misses work. At that point, he gets medical attention, and he sees the primary doctor. And the primary doctor, or the rheumatologist, whoever it may be, the first thing they start him on usually when they realize it is gout, by saying location, severity, all the clinical presentation looks and smells like gout, they said, usually, besides the anti-inflammatories, let's start you on something. 2 medications are usually started hand in hand. If his kidney functions okay, is they always ask you to get blood work first. Is first medication allopurinol. We need to lower your uric acid burden. If your uric acid normal range is anywhere from 5 to about 6.5 to up to 8, and they have patients who come in with 10, 12,
Yes,
tremendously.
I know that. Yes,
Of
tremendous. Over 6 is considered a high uric acid level.
Correct. And once they see that on the blood work, they know this patient, Joe, has a tremendous uric acid burden. Let's get his uric acid lower. Because once you have the uric acid, as you said, below 6, very infrequently, about 90% of the time, you will not have a flare-up if you keep it below 6, because that's the saturation point where it starts becoming more tophaceous and burdensome.
Right, and accumulating.
Yeah.
And what about colchicine?
That's another medication that's used hand in hand. That one does not work by inhibit. So allopurinol works by breaking down the uric acid. Colchicine works by going around the uric acid crystals, microtubular formation, and it stops it from being so painful.
Yeah.
So they're used hand in hand. One is to reduce the pain and decrease the flare-ups, which is the colchicine, and then the allopurinol is to actually break it down. And they need to be on these medications for quite a while in conjunction with their lifestyle changes of eating healthy, losing weight, hydrating, and avoiding those triggers.
Right.
So it's hard to change a young male's lifestyle of not going out with his buddies.
Yeah, so I mentioned the history. A little bit of medical history was when Christopher Columbus came over, Queen Isabella of Spain, of course, gave him the option of coming over. He brought back with him extracts of the cinchona bark, which was colchicine.
Correct.
And that became all the rage in the Middle Ages to treat gout. Of course, in the royalty. You couldn't get cinchona bark if you were just a regular person.
Yeah.
Yes, you had to be a member of royalty. But that's fascinating. So then there are people whose uric acid doesn't go down.
So every case is case by case.
Yes.
And I think the most important thing is having a good relationship with your patients and educating them of what the triggers are and the unbelievable need for compliance with their medications. So a lot of the patients, they start on the medications and somehow they have a side effect and they don't want to stay on it. So I preempt them by telling them all the possible side effects, especially of colchicine. Colchicine is notorious to create diarrhea.
Yes.
You take a guy who can't walk and you start giving him tons of colchicine and he gets diarrhea, that's a bad scenario.
It's a very bad situation.
So I pre-warn them.
So you got to be careful.
Of course. You're going to stay close to a bathroom, be careful for what's going on, and this is how you're going to change your lifestyle.
Yes.
And usually, from my experience, I have 2 or 3 conversations with the patients because they don't learn the first time. Yes. It's after the second or third attack that they realize, and with help from their spouse, who urges them and brings them to the office.
Or girlfriend.
Yeah, exactly. To bring them in to get them treated. And once they understand what they have to do and they start doing it, they do okay. They have to be compliant with the allopurinol. And allopurinol, we start at a low dose so they can tolerate it. And the good thing about allopurinol, you can titrate it higher, which is good. Yes. So I've had patients, but this is back 20 years ago, where they had big tophus. We didn't have other medications. And the standard dose for allopurinol was usually 300 milligrams.
Exactly, 300 milligrams a day.
And I learned that you can go higher than that if their kidney function is good. And all of a sudden, I had one patient that I love to death, older guy, he's about 92 now. He used to fly a helicopter, terrible tophi. I followed him for the last 15 years. All he stayed on was allopurinol, 450 milligrams. And every 6 months, he would take pictures of his tophi getting smaller and smaller and smaller because he was persistent on taking the right. And people say you have to be careful. That's a high dose for the elderly. So it worked. He did fine. It was close monitoring. And now the tophi went away.
Right.
But there's other patients that even with the higher dose allopurinol, we have to consider other treatment options.
Right. So Dr. Kimmel mentions the guy who was 92. And of course, we worry, for those of you out there who are elderly, after a certain age, the filtration of your kidney begins to decrease, gradually decrease. It doesn't mean you're in kidney failure. It just means that the kidney function will go down, and that sort of encourages more the appearance of gout in elderly, particularly men, and certainly now women.
Absolutely.
So then there are those. What about febuxostat? I don't want to mention the product name because
Yeah.
it's probably not kosher to do that at this point.
Okay. But
Febuxostat.
It's a great medication that was studied. It's also a xanthine oxidase inhibitor, just like allopurinol, but it's intended that it can be used in patients who have renal insufficiency, not fully class 4 renal failure, but if they have renal insufficiency where the kidney, because remember, the uric acid comes out through the kidney. So as you get older, it doesn't function as well. You want to give something safe.
Right.
So the febuxostat has 2 doses. And in patients that I couldn't give the allopurinol, I gave them febuxostat, and it did lower the uric acid safely.
Yes.
So it worked out fine. But not everybody's a candidate for it.
Yes, it's a good drug, and it's thank goodness it's on
generic.
the scene. The generic now is really important. And then there's the pegloticase, and that's a complicated end. And you want to explain that whole thing.
That one is actually more of an enzyme that works exactly at the xanthine oxidase level of breaking down the uric acid to a soluble form of it that you can get out.
Yes.
But it's only administered intravenously. It's not a pill form.
Yes.
It's not an injection.
Yes.
It has to be administered under very supervised environments in the hospital or in the offices, where it actually works at the level that it breaks down the enzyme and it melts the tophi within a few number, and it works probably 20 times more potently than an allopurinol and so forth. And it works really number one, it was used in tumor lysis syndrome from the resburicase, but they extrapolated it to, for uric acid, for pegloticase.
Yeah. And pegloticase, is that a monoclonal of sorts?
I believe so, yes.
It's a monoclonal. So the danger there, and I think we've spoken perhaps in a previous program about, if you give a protein to a person, their immune system, if it's a foreign protein, will react to that particular drug, that monoclonal antibody, and it will make antibodies against that antibody. And then the drug will no longer be very efficacious because, like your immune system removes foreign materials, it will remove this protein drug. So there are ways that the doctor's too complicated to go into, but a rheumatologist should be giving pegloticase.
Correct.
And the rheumatologist has got to do certain things to protect the patient's immune system from attacking the drug. Then the drug becomes non-efficacious and you can never use that drug again.
Correct.
Because the immune system sees it as like a bacterium or a virus. So that's a very new advance. And it's a spectacular drug. And it works really good in melting those tophi.
I've had tremendous success in about 4 patients. They had 2 versions of it. The first version where they didn't know, as what you just said, the antigenicity of it, where the patients would take it without the proper, our immune systems are so smart in regards to it, it'll recognize that it's foreign. And then the next time you give it, the body will completely reject it. And they didn't do enough the first time around when it came out to protect the immune system in that regard.
Yes.
Now, the version 2 of it has worked wonderfully with my patients, that we give them something to protect their immune systems first from when they recognize the medication. And you see within a 6-month period, these tremendous tophi. This one gentleman couldn't make a fist because he had all these bumps here. Every infusion, you would see it getting smaller and smaller. He could put his rings back on, and you can see the joy he had that he's becoming functional again.
Yeah, that's amazing.
It really is.
It is amazing. For those of you out there who have experienced this, you can appreciate the effect of tophi on both your hands and your feet. These collection of uric acid crystals. What about pseudogout?
Pseudogout's an interesting topic because that's becoming more and more common with the aging population. So when you have gout, which is uric acid crystals, pseudogout is calcium crystals, calcium pyrophosphate crystals, which accumulate over time. And they're both extremely inflammatory. The joints get really swollen, really angry, and it looks the
It
calcium
looks like rheumatoid arthritis, doesn't
Yeah.
it? Yes.
It looks like, and it looks like gout many times too.
Yes.
But it seems like more gout of the elderly. A lot of times gets confused for like the pseudo gout attacks get confused for gout or
Yeah.
polymyalgia rheumatica because of the shoulders, the wrist, and the
Right.
knees.
Yeah, polymyalgia rheumatica, for those of you who don't know what that is a condition of people, say, over 65 who get stiffness in their upper extremities. Their strength doesn't change, but the tenderness of the muscles
Correct.
is pretty profound, and it's usually treated with cortisone preparations. So, but pseudo-gout can be confused with that, but pseudo-gout itself is something that is readily seen on an x-ray. Am I right?
Yes. You have to get the x-ray. So the
Yes.
problem is the patient comes in
Yes.
and they go, my wrists and everything's hurting me terribly. And this one wrist, doctor, is killing me. It's red and it's angry. And people go, maybe it's a tendonitis. Oh, it's probably gout. Again, try to get fluid if you can. If you can't, you can. But this next best step is exactly what you said. Get an x-ray because calcium comes out radial. You can see the calcium deposits
calcium in the joint. Yes.
Absolutely.
Yes.
And then you know.
And regular gout you don't see by x-ray.
Correct.
It's invisible to x-ray film. So that's really, really interesting.
And it's much more as the aging population happens.
Yes.
And we as rheumatologists and just a general practitioner also sees more elderly patients.
Yes.
They have this, and it's pretty common that you get a patient who comes in saying, I have terrible joint pains. And a lot of times they'll say, oh, you're getting older. It's probably just a tendon. I want you to do some physical therapy.
Right.
Work them up, because as you work them up, you'll start finding that many of these patients do have pseudo gout.
Yes. And how do you treat pseudo gout?
So pseudo gout you have to be careful because, again, the population is elderly.
Yes.
You don't want to start blasting them with anti-inflammatories because their stomach and their kidneys.
Yeah. Now, the anti-inflammatories, I just want to make this point because we have a lot of elderly people watching. You can't take a lot of ibuprofen, naproxen, and other things like indomethacin, all of we call them non-steroidal anti-inflammatories, because what they do to your kidney, which is already lowering its function as you get older, it crimps the arterioles, the small arteries that go to circulate the blood through the kidney. So you're just going to induce kidney insufficiency or kidney failure if you take too many anti-inflammatories. It's better to go and find out what it is.
Correct. 100% correct.
Yes.
So when it comes down to pseudo gout, you want to limit the amount of anti-inflammatories they take. But the one thing that works wonderfully well, as you just said, the non-steroidals, on the other hand, we have the steroidals.
Right.
So that's actually corticosteroids that work wonderfully at decreasing inflammation. But we have to keep in context that many of these patients might be diabetic.
Yes.
And steroids with diabetes is not a good match.
Yes. So steroids he's talking about are prednisone, cortisone, hydrocortisone, etc. Depo, the Medrol dose packs. Medrol. I mean, people come in and they say, oh, I'm miserable. Can I have a Medrol dose pack? That's sort of like the inappropriate antibiotics that I talked about earlier. Now we have clam blood to deal with that.
It's exactly what they do.
But this is what they do to doctors. And I know that speaking to many physicians and hearing that, it's so much easier just to give them a Medrol dose pack and send them out. But that's temporary.
It's a Band-Aid, as you just said.
It's a Band-Aid. Yeah. It's temporary, and you don't want that for a long time.
Yeah. If they're not diabetic and they have multiple joints, it does make sense to do that, to put the little fire out and just as a Band-Aid. But then the underlying treatments we really have goes back to colchicine again.
Yes.
We use colchicine for pseudo-gout also, not just gout, but pseudo-gout, and it works well. But as you said, we have to watch their kidney function.
Yes, kidney function is important. And we concentrate on geriatrics. That means those are doctors for older people. And geriatricians are out there, and they are expert in treating older people for things like pseudo-gout, polymyalgia, and also regular gout. Anything that we want to finish up with, that we want to add to our discussion? We really covered a lot.
Yeah. I think gout's a very common disease that if the patients are educated about it, they do well. If they can watch their diet, lifestyle, and all cut out the drinking, and wine from my understanding is okay, but the spirited alcohol, so all these other things, watch what they eat.
Scotch, whiskey, bourbon.
No go.
No go.
I have some of these guys, the veterans.
I had a guy who was wondering why his gout attacks occurred when he would drink tequila like 3 days a week. He said, it's only 3 days a week, but it was a lot of tequila.
Yeah. And they know because the next morning they're hurting.
Yeah, that's exactly correct.
But if they hydrate with tons of water and they cut out all the triggers and they follow what they have to do, the patients actually do really well. The pseudo-gout, you're very limited because that's just a normal metabolic process that goes on over time. I think the most important thing is patients, as you said before, have to advocate for themselves.
Right.
Saying, can you check me for this? Can you check? Could this be pseudo-gout, doc? Could this be gout?
Yeah, because most doctors aren't going to think about it, or not most. Many doctors are not going to think about gout, pseudo-gout, other things like polymyalgia. It's much easier just to say, oh, I think you have rheumatoid arthritis.
Correct.
Or you have osteoarthritis, which is degenerative joint disease. And then, boom, the patient continues to suffer until somebody comes up with the idea that it might be gout.
Yep.
Well, Dr. Kimmel, I want to really thank you for joining us today. It was really a wonderful discussion, and I think our viewers are going to really learn a lot from this particular episode. It'll go out on the airwaves, and those of you who have any questions, please email us at askdrbob@healthfrontierspod.com. And thanks for looking at Health Frontiers. And again, thank you, Dr. Kimmel.
Thank you for having me.
Thank you for joining us on Health Frontiers. I hope today's episode provided valuable insights into your well-being. Remember, this podcast is not a substitute for professional medical advice, but a source of knowledge and guidance. If you have any questions or topics you'd like us to cover, please reach out. Make sure to like, subscribe, and visit our website at www.healthfrontierspod.com. Join us next time as we continue our quest to uncover the latest in health and wellness. Stay healthy and empowered. Until next time, I'm Dr. Bob.